Chapter 3: Promoting Positive Outcomes of Drug Therapy. Selecting and prescribing the most appropriate drug is just the first step in providing safe and competent medication therapy. Ensuring positive outcomes requires establishing a medication education plan, monitoring positive and negative patient responses, identifying and addressing issues of non adherence, and managing the patient's complete medication regimen. So, medication education. Probably no other provider action influences the patient's commitment to carry out a medication plan more than medication education. This is not only provides an opportunity to explain the importance of the medication, but also allow the provider to dispel rumor about medications that often lead to therapy failures. Moreover, education reduces medication errors by empowering patients with accurate information and clear guidelines. Medication education components. There are basic components that should be included when teaching about any new medication, which include the medication's name, its purpose, its dosing regimen, its administration, adverse effects, any special storage needs, associated laboratory testing, food and drug interactions, and the duration of the therapy. Each of these is discussed in the following section. So, the medication name. Patients need to know the name of the medication they are taking. Unfortunately, when taking a medication history, we still have patients who refer to medications by their understood purpose, such as the blood pressure pill, rather than by their name. This creates a challenge for providers who need to select appropriate therapy. It also increases the risk for medication errors. If we teach patients the medication names, we can avoid this concern. Both the generic and the brand name or trade name should be given, or at least be included in written handouts. This knowledge can be especially important for the patient who travels and may be treated by providers unfamiliar with the patient's history. Knowing both empowers the patient to catch medication errors in the event of that two different prescribers or providers prescribe the same generic drug under different brand names. The purpose. Patients are more likely to participate in activities when they know those activities produce positive outcomes. The same is true of taking medications. Knowing the reason the medication is prescribed propels the patient to follow through with the medication plan because the patient is aware that this action helps to achieve the therapeutic goal. Dosing. The dosing regimen needs to be reviewed with the patient even though it is written on the prescription label. Doing this ensures that the patient understands how to take the medication and provides an opportunity for the patient to ask questions. It is important to be specific when explaining the dose regimen. For example, 4 times a day may be interpreted in various ways by different people. Can the medication be taken every 4 hours for 4 doses, or does it need to be spaced out evenly to every 6 hours? Does once a day mean that it can be taken at any time, or is it better to take the medication in the morning or in the evening? Patients need to know what to do if a dose is accidentally skipped. This is also a good time to explain why drugs should be taken exactly as prescribed. Administration. A common patient concern is whether medication should be taken with or without food. This routine information should be provided for all drugs. Patients also need to be informed of common administration needs that many of us take for granted. For example, suspensions should be shaken or rolled if shaking causes foaming to equally disperse ingredients before administration. Finally, some drugs require a special apparatus for administration. Inhaled drugs are a common example. Patients need to see how these are administered and should be able to repeat a demonstration before leaving with a prescription. Many manufacturers provide a dummy device for teaching purposes. Adverse effects. Some providers and other healthcare workers hesitate to discuss a drug's potential adverse effects. Some fear that doing so will lead to the patient's refusal to take the medication. Although that concern is understandable and the consequences may well be true, patients have a right to know the potential harm that may result from therapy. Therefore, providers are ethically obligated to divulge adverse effects and other risks. That said, often the approach used in discussing these can make a difference in how patients view them. You probably know patients who worry about taking drugs when the product labeling lists dozens of adverse effects. Patients may not know that for most drugs, most adverse effects occur in less than 1 to 2%, and those taking the drug. Most patients are unaware that the long list of adverse effects represents all effects reported during a clinical trial, regardless of whether a direct association to the drug is known. Furthermore, labeling doesn't mention that sometimes the incidence of adverse effects in the placebo group is similarly high. An example of this in clinical trials of lovastatin, 1.8% of subjects taking 40 milligrams reported myalgias. However, 1.7% of subjects taking a placebo also reported myalgias. When discussing adverse effects, focus on the adverse effects that are common and avoid undue attention on rare and unanticipated effects. If complex effects such as liver injury or pancytopenia may occur, teach patients the signs and symptoms to report. Let patients know that many adverse effects, most commonly nausea and sedation, are usually temporarily and go away with continued medication use. In these discussions, it is also beneficial to emphasize the benefit over the risk. Patients are often willing to endure short-term adverse effects for long-term health improvements. Storage. Storage is an important concern for some drugs. Some examples, some antibiotic suspensions, insulins, and rectal suppositories should and need to be refrigerated. Medications such as sublingual nitroglycerin and dabigatran, also known as Pradaxa, need to be stored in their original container to prevent drug breakdown and loss of potency. Your lab testing. Laboratory testing is sometimes necessary to determine whether a medication remains safe and effective. For example, liver enzymes may need to be checked periodically for drugs that can cause liver damage. Serum drug levels may need to be checked when maintaining therapeutic levels is challenging. Patients need to know if special testing will be needed. They also need to know why the monitoring is necessary, because those who understand the purpose are more likely to adhere to testing schedules. We recommend teaching what, when, where, why, and how when giving these instructions. The following box here is a patient teaching for drug monitoring. So it's a good spot to hit pause if you'd like to review. Food and drug interactions. Many medications interact with certain foods or other drugs, including alcohol and other recreational drugs. Patients need to know of any potential interactions and the consequence of those interactions. They also need to know if the problem with interactions can be solved by taking substances further apart, or whether they need to avoid an interacting food or drug for the duration of the therapy. An example of this are antacids, may be taken with most drugs as long as administration is separated by 2 hours. However, patients taking flagyl must avoid alcohol for the duration of therapy. So, the duration of therapy. It is important to let the patient know if medication therapy is being prescribed for a short time. such as antibiotics for an acute infection, or whether ongoing long term medication therapy is anticipated, such as thyroid hormone therapy for hypothyroidism. Failure to recognize the need for a prolonged therapy is a common reason patients stop taking medications prematurely when a prescription runs out. So, the written instructions. Medication information is notoriously easy to forget, especially for patients taking numerous medications. We recommend accompanying all verbal education with written instruction. For those who are unable to read due to literacy or vision problems, video or audio instructions can be applied. Best practices in developing written patient education materials abound in literature. The following table here provides a list of those for which there is a greater consensus. An excellent resource for written patient education material is available at the CDC Health Literacy. So here is this table. It's a good spot to hit pause. I know the writing is a little on the small side, so I'll leave this up a little longer. Monitoring. As mentioned in Chapter 2, monitoring is an important consideration in medication therapy. Ongoing monitoring of positive and negative patient responses and acting on those responses in ways that increase benefit or decrease risk is essential in ensuring optimal outcome. There are three primary reasons for drug monitoring: determining therapeutic dosage, evaluating medication adequacy, and identifying adverse effects. Each of these purposes is discussed in the following sections. So, Table 3.2 here provides some common examples of drugs that require periodic lab monitoring. So, for instance, patients on ACEs and ARBs, amiodarone, anti-diabetic drugs, anticonvulsants, digoxin, diuretics, those potassium sparing, diuretics dithiazide and loop, lithium, methotrexate, NSAIDs if you're using long-term use, your statins, your thiazolidinones, your thyroid hormone, and warfarin. Determining therapeutic dosage. Many drugs have a narrow therapeutic index, also known as the NTI. Examples include carbamazepine, digoxin, lithium, phenytoin, and theophylline. For those drugs, the difference between an effective dose and a lethal dose is very small. To ensure safety, periodic measurement of serum drug levels is needed when drugs with a NTI are prescribed. This not only determines whether the drug is in a therapeutic range, but also provides an opportunity for fine-tuning of dosage. If a drug is nearing a toxic level or a subtherapeutic level, the provider will make a dosage adjustment accordingly. How often monitoring is needed varies for each drug. Additionally, patient factors, such as a poor liver or renal function, may determine the frequency of drug level monitoring. For some drugs with an NTI, a therapeutic dosage is determined by means other than the serum drug level. Warfarin is a drug that illustrates this method. Instead of ordering a serum warfarin level, optimal dosing is determined by measuring the prothrombin time with international normalized ratio. So, evaluating medication adequacy. For some drugs, evaluation of effectiveness can be determined easily. For example, if an analgesic is given, effectiveness is determined by asking the patient to rate the pain on a scale of 0 to 10. Similarly, the adequacy of an antihypertensive medication can be evaluated by checking the patient's blood pressure. Evaluating medication adequacy is not so simple for some conditions, however. Some conditions do not cause obvious signs or symptoms. Hyperlipidemia is a common example. Signs and symptoms often do not appear until after decades of accumulated damage have occurred. Other conditions may be manifested by signs and symptoms that are not easily quantifiable. A common example of this condition is hyperglycemia, associated with diabetes. Some people display obvious signs and symptoms with hyperglycemic, whereas for others the evidence is much more subtle. For conditions such as hyperlipidemia and hyperglycemia, lab testing offers a precisely quantifiable measure that can be used to gauge the effectiveness of medication therapy. A hemoglobin A1C level can be used to evaluate glucose control, for example, and lipid panels can be used to determine the effectiveness of hyperlipidemia management. Identifying adverse effects. One of the most common uses of drug monitoring is that of monitoring for harm. This is a proactive undertaking to identify problems early, before they progress to the point of harm. Many drugs are potentially dangerous. For these, monitoring depends on the type of potential injury. For example, if a drug can cause liver injury, periodic monitoring of liver enzymes is needed. If a drug can cause bone marrow suppression, periodic monitoring of a complete blood count to assess for anemia, leukopenia, or thrombocytopenia is warranted. In addition, baseline laboratory studies are done before initiating therapy. Adherence. Medication non-adherence costs the United States healthcare system approximately $290 billion each year. It is often directly responsible for disease exacerbations, avoidable hospitalizations, transitioning to long-term care, and premature death. Medication adherence can be defined as the extent to which patients take their medications as prescribed by the provider and agreed to by the patient. The, pa- the patient who adheres to the agreed on medication regimen takes the medication in the prescribed dose at the prescribed frequency for the length of time indicated. In 2013, the National Community Pharmacists Association released Medication Adherence in America, a national report card. The NCPA report identifies 6 non-adherent behaviors. They are in percentage of frequency as follows: a missed dose, 56 or 57%, forgot to take a dose, 30%, did not refill medication in time, about 28%, took a lower than prescribed dose, 22%, did not refill the medication, 20%, and stopped taking the medication, 14%. The reason given by patients to explain the non-adherence provides additional insight, again, in the frequency of occurrence. So forgot to take it, 42%, ran out, 34%, was away from home, 27%, was trying to save money, 22%, didn't like the side effects, 21%, got too busy, 17%, the medicine just wasn't working, 17%, didn't believe the medicine was necessary, 16%, or didn't like taking the medicine, 12%. These documents can offer valuable insight for the healthcare provider. Moreover, they beg the question: what could the provider have done differently to address issues of non-adherence proactively? In examining these 5 primary patterns emerge. These are forgetfulness, lack of planning, the cost, dissatisfaction, and altered dosing. An honest and open discussion that respects both the patient and the provider perspectives can be an important facilitator to promoting positive outcomes. Individualized solutions that address the specific patient concerns are most likely to be successful. That brings us to forgetfulness. The most common reason cited for non-adherence was that the patient simply forgot to take the medication. Studies have demonstrated that medications are easier to remember if they are aligned with common daily activities. An example of this is morning medications may be taken on first arising. or with breakfast. Doing this establishes habits, which are more difficult to forget. Several memory aids are available to help patients remember to take their medications. Drug organizers are probably the most common tool used. If these are filled at the beginning of each week, the patient can tell at a glance if medications have been taken on any given day. Numerous apps are also available for various electronic devices. These can be programmed to alarm or deliver a verbal message when it is time to take a drug. Some patients have found that medication administration records, similar to MARS, used by the nurses in hospitals, can be helpful. One company at medactionplan.com offers a free online service that patients can use to set up a personalized MAR that include the option to receive reminders via email or text message. Lack of planning. Aligned closely with forgetfulness is the lack of planning. In this category, we include those statements aligned with failure to refill medications, whether because the patient was too busy, away from home, or ran out for other reasons. Most pharmacies offer reminder notices, either by email or automated phone calls, as part of this regular service. If being too busy is a concern, a pharmacy that offers a home delivery service or a mail delivery service is a viable option. The cost. As mentioned in Chapter 2, cost should be considered initially when selecting an appropriate drug. Sometimes, however, there are no adequate substitutions for a necessary but expensive drug. Fortunately, prescription assistance programs, also called patient assistance programs, and pharmaceutical assistance programs are widely available. These offer steeply discounted drugs for those who meet eligibility requirements. There are three sources for PAPs: pharmaceutical companies, government run programs, and nonprofit organizations. Table 3.3 offers a program sampling. If you do not find what you need here, your likely best resource for reliable information is the local pharmacist. Warn patients to be aware of discount cards that are not affiliated with known reputable organizations. Unfortunately, some criminals use these applications for fake cards for illegal purposes. So here is that table of patient assistance programs. A good spot to hit pause if you need those for yourself. Which brings us to dissatisfaction. The issue of dissatisfaction as a reason for non-adherence highlights the need to identify what medications are taken and to discuss any concerns with the patient at each encounter. It is essential to uncover the reason for dissatisfaction. Often, the problem can be easily addressed by simple intervention. For example, taking medications with food can reduce adverse effects of nausea and gastrointestinal distress in many instances. Changing to a sustained release drug may be all that is necessary to address problems with inconvenient dosing. If the patient believes a drug is ineffective, it becomes important to discuss the patient's expectation of the drug therapy and what can be realistically achieved. For some conditions, such as obesity, change may come slowly. For others, such as hypertension, the medication may cause the patient to feel worse without a perceived benefit. If the drug is truly an important one, this may be a good time to explore with the patient any consequences of not taking the drug and whether that patient is willing to assume those risks. In some instances, the patient may decide to assume those risks rather than take the medication. It is within the patient's right to do so. Altered dosing. We were concerned to see that more than 20% of patients took lower than the prescribed dose. The reason were not made clear. However, the consequence is thus. A subtherapeutic dose is no better than no dose at all. Most drugs must reach a level sufficient to cause a therapeutic effect. If the drug does not reach that level, it isn't helping. In that case, Or in the case of certain antimicrobial drugs, subtherapeutic levels may actually cause harm if the bacteria develop resistance as a result. This finding emphasizes the necessity of not only reviewing which medications are taken at each encounter, but also asking whether the medication are taken as prescribed. If dosing is altered, it is imperative to determine how and why, and then to educate the patient regarding how alterations in dosing affect that outcome. Managing medication therapy. In addition to the medication review undertaken at each patient encounter, a more comprehensive and deliberate review is needed periodically. This review should be approached with the intent purpose of determining whether there are better options for medication therapy. Inherent questions that must be asked about each drug include the following. Is each medication accomplishing its intended purpose? Is each medication still necessary? Has the patient's condition changed? Do adverse effects or risks outweigh the benefit that some drugs provide? What would happen if some medications were no longer prescribed? What problems does each medication create for the patient? Is a medication problem amplified by other drugs the patient is taking? If a medication is necessary but problematic, are drugs with fewer adverse effects available? If polypharmacy is an issue, are there ways to decrease the number of medications? Will a combination drug simplify management? Is a symbol is a single drug available for management of two different conditions? Ideally, these reviews should be carried out in collaboration with the patient or patient family so that nothing is overlooked. Medication regimens can then be optimized to eliminate unnecessary drugs, add new drugs if necessary, and ultimately improve the patient's satisfaction with care. So, in summary, we have examined four opportunities to promote positive outcomes in drug therapy. Patients need adequate drug education in order to take drugs correctly and to avoid complications associated with therapy. Monitoring provides a method of ensuring safe and effective therapy. Promoting adherence by addressing common causes of non adherence proactively can ensure ongoing therapy without interruption. Finally, scheduled medication review with the intent to optimize medication regimens based on patient experiences and need can help to promote positive outcomes.